participants to actively interact. Post your questions. Post your questions in the chat box as and when you get them. We can take up all the questions at the end and discuss. Hand over to you, ma'am. Please. Thank you.
Good afternoon to everyone. Am I audible?
Yes, you are.
Good afternoon, everyone. We'll be discussing few practical aspects regarding this transfusion strategies and practices in our children in our hemato-oncology wards and daycare. So there are few key questions which are central to this. Is who are the patients who require transfusion, and when do they require transfusion? What is the threshold for transfusion? Because if we reduce the amount of transfusion, the amount of errors, the amount of transfusion reactions, adverse effects, all this will be reduced to a minimum. And how much to transfuse? And what are the precautions that should be followed during transfusion? And what can go wrong during transfusion? And if something goes wrong, or if there are any transfusion associated reactions or adverse effects, and how what to do should be the basic tips and management. So we will discuss the first will be what are the blood components and their indications, and the medical legal significance of transfusion therapy. What are the steps that should be taken prior to transfusion, during transfusion, and what are the transfusion related adverse effects and management. So, coming to the anemia in pediatric cancers, more than 97% of the children with acute leukemia are anemic at the onset, and virtually all of them develop anemia during therapy. And with regards to the solid tumors, the figure is around 50 to 60%. So anemia is significant because it interferes with the quality of life, resulting in symptoms like breathlessness, easy fatigability. It also interferes with the delivery of therapy. It has been seen that radiotherapy becomes less effective in presence of anemia. And moreover, these children, along with dealing the cancers, it is also phase of their growth and development. And presence of anemia interferes with their growth and development. So the causes of anemia in these children are multifactorial. It can be because of decreased production or increased losses and destruction, which can be contributed by nutritional causes, and more importantly, they can be because of marrow involvement. It can be because of the chemotherapy and radiotherapy we give. There can be impaired marrow mobilization, and there can be component of anemia of chronic disease. The endogenous erythropoietin may also be suppressed, and presence of infections will also add to decreased production. And there can be increased losses because of hemolytic, either because of hemolytic anemia, bleeding, repeated. These children have repeated samplings, and therefore there is a proportion of sampling losses. There can be shortened RBC survival because of various factors like sepsis, DIC, and lastly, these children are also prone to develop alloimmunization and immune-mediated early destruction of the RBCs. So the RBC transfusion is a rapid, safe, and cost-effective therapy for anemia. So the typical volume of transfusion that should be given to these children is described as 10 to 15 ml per kg over 4 hours. And here the duration is important, is it has to be given over 4 hours, and any blood product that should be discarded. And however, in children who are severely anemic with hemoglobin less than 5, or having congestive cardiac failure or evidence of fluid overload, the amount, this volume of 10 to 15 ml should be reduced to around 5 to 10, because depending on the hemodynamics and respiratory status. So these are the few basics about RBC transfusion. Now, when should it transfuse? It's not. WHO defines anemia at a level of less than 11.5 to 12, depending on the age group. Do all of them require transfusion? The answer is no. There's been have been few meta-analyses which have compared restrictive strategy of transfusion compared to a more liberal transfusion strategy. So they have found that when the hemoglobin threshold is kept at lower threshold 7 to 8, it doesn't make any difference in the hospital stay or mortality or any symptomatology. And there is also reduction in the transfusion requirement by 43%. So in hemodynamically stable patients, the transfusion cutoff should be around 7 to 8. However, in the unstable patients, we can keep a higher threshold of 10. Now, briefly coming to the platelet transfusion, these platelets can be derived from the whole blood, either from the donated whole blood or by apheresis. From the whole blood, the various preparations are by Buffy-Coat method or platelet-rich plasma method. Random donor platelets contain 5.5 into 10 to the power 10 platelets suspended in around 50 to 60 ml of plasma. However, the platelet consent amount is around 5 to at least 5 to 6 times higher in an STP, which contains around 3 into 10 to the power 11 platelets. So roughly, the increment with one STP it will be around at least 5 to 6 times that of RTP. Now, when should you transfuse the platelets? In presence of thrombocytopenia, any level of platelets with presence of bleeding, we should transfuse. And children with who are stable afebrile with platelet less, that the threshold is less than 10,000. However, in presence of fever or hemodynamically unstable, the cutoff should be increased. And in children also undergoing stem cell transplant, the platelet cutoff should be 10,000, provided they are stable and hemodynamically stable and afebrile. But there are specific situations where you can keep a higher platelet cutoff, like presence of hyperleukocytosis, cytic leukemia, sepsis, DIC, and in presence of major bleeds. So, and prior to procedure also, the platelet count should be higher. In a routine lumbar puncture, not the first lumbar puncture, the platelet target should be 20,000. Whereas the lumbar puncture for the first diagnostic marrow during diagnosis of ALL should be much higher. Those the recommendations, few recommendations recommend more than keeping a platelet count more than 1 lakh. This practically becomes very difficult. So at least a platelet count of 30,000, 30 to 50,000 depending on centers is suggested. For other invasive procedures like central incision, should be 50 to 1 lakh depending on the major surgery. And even till it is the what should be the platelet threshold for doing undertaking procedure of bone marrow aspiration. So I'll do it at end of the class. And platelets do not contain the surface antigens of ABO and RS. Therefore, theoretically, there is no risk of incompatibility. However, in addition to the platelets, they do contain some amount of RBCs and WBCs as well, which contribute to the reactions as well as alloimmunization. Therefore, preferably the platelet transfusion should be ABO compatible. However, it is not mandatory. And this can be reduced by leukodepletion and irradiation. So leukodepletion, as you know, can be done by leukocyte filter. It can be either pre-storage or pre-transfusion, and subsequently irradiation can also reduce the risk of alloimmunization, where it is mandatory in settings of transplant and T-cell suppressive therapies like fludarabine. Now, what's be done for transfusion in hemolytic anemia? In hemolytic anemias, these children will require prolonged and more frequent PRBC transfusions, so there will be high risk of alloimmunization. And this risk of alloimmunization is much higher in patients with sickle cell anemia and non-transfusion dependent thalassemia. And if there is alloimmunization, and the degree of rise in hemoglobin is less than expected, or even sometimes the post-transfusion hemoglobin is less than the pre-transfusion hemoglobin. And there is a role of the minor antigens like C, E, and KEL antigen. So, the routine transfusions should be with extended typing and matching, particularly in theoretically in all cases of hemolytic anemias, but at least in cases of sickle cell anemia and non-transfusion dependent thalassemia, where the risk of elimination is much higher. And in patients with prior history of hypersensitivity or anaphylaxis, saline nursing can be done. Now coming to the blood safety. So the various components of blood safety are the donor should be safe, the blood should be safe, and the transfusion process should be safe. Now, a few medical legal issues associated with blood transfusion therapy. Blood has been declared as a drug in the Western settings much earlier, and subsequently in our national blood policy also, blood components have been declared as drugs. And blood transfusion has been declared as an invasive procedure. So, as per any invasive procedure, an informed consent is mandatory from the parents or the guardians. And similar to the other invasive procedures, the transfusions and details, including any complications, should be well documented, because it can lead to various medical legal issues subsequently. So, what do we do prior to when we are planning to transfuse a patient? So first of all, so confirm the indication and confirm whether the child is going to require any transfusion or not. So this in unnecessary transfusions where it is not strictly warranted will not only increase the burden, also it will also increase the risk of various other transfusion related adverse effects and reactions. And next is should take can inform consent and document it well in the inner files. And the next important step is the filling of the complete requisition form. So the minimum requirements in the requisition form should include the patient identification details, which should be and the patient should have a proper identification ID in the hospital, including the ward and bed number, and the type, blood component, which type is required, and the amount of blood component required. And next is the drawing the blood sample and labeling at the bedside. So this is very important, because labeling the blood sample at any place other than the bedside does increase the risk of errors and transfusion mismatches significantly. So labeling can either be done prior to just prior to taking the sample, or just immediately after taking the samples, and it should be done at the bedside. And one important thing to remember is, so never use in any unlabeled samples, thinking that this blood sample is probably of this patient, and we may end up using a wrong blood sample for the cross match. So these are the essential steps. Particularly the third and fourth steps are more important to prevent any mismatch transfusions. So the basic do's and don'ts is always label the blood sample at the bedside, not at any other place. And it should be done either immediately before or after sampling, and requisition form should be filled properly. And if there is any doubt or discrepancy at any of the step, we should better discard the sample and take a fresh sample. And should not send any unidentified sample or previous sample which has been labeled properly, to prevent these errors. So then we have sent the samples for to blood bank for cross matching, and after obtaining, what should be done? We should confirm and check three components. Is the blood given to the issued from the blood bank, is it right or not? We check the details of the blood properly. So check the compatibility report, and we should double check the patient details, whether we are transfusing the correct patient or not. And this is called a positive patient identification, and it should be ideally done with at least two identifiers, including the name and any other identifier, like the CR number, VHID, or the surname or father's name. Because it has been seen that, and using just one identification, there have been transfusion errors, like transfusing a blood product to another patient with the same name. So in the blood unit, we should check whether the blood component has the correct ID number or not, the correct blood component or not, the volume which we have required or not, and the blood groups, which should be, is it compatible with the patient's known blood group and date of expiry. And we should also for the check the blood bag for any signs of like any, is there any leak or not? Are there any visible clots or not? And if any of these things are there is any fault in any of this, we should immediately return the blood bag to the blood bank. Then we should check the compatibility report, whether the ID has been labeled correctly or not, the expiry date, the compatibility status has been written correctly or not, and the screening for various infectious diseases, and followed by the signature of the person who has performed the compatibility testing. And third is the checking the correct patient, whether the patient is the blood is being transfused to the correct patients or not, and is there any specific requirements like leukodepletion, rewarming, or irradiation is needed or not. And this is confirming the patients using the second identifier other than the name. Then check the vitals and document the vitals, and then start the transfusion. So all of you know regarding the compatibility, which blood group, which patients of which blood group can receive PRBC from which blood group. So always the first choice is the same blood group, and the second choice is either it can be the next compatible which doesn't have the antigen subunit that, followed by and O can be the other universal donor. And um, a recipient of any Rh negative can never donate blood from a patient who is Rh positive. And next is how to administer. Must check the vitals prior to transfusion and document it well in our files. And next is to what's it used? So use a blood transfusion set, or can also use an infusion pump. However, when we are using an infusion pump, it should always be done with a filter. Because transfusion using a normal IV set can release some clots that can be detrimental to the patients. So routinely, rewarm, often you see for all the patients, and the attendants are told to rewarm the blood. However, it is not routinely needed, except where transfusion is needed in neonates, or the patient has hypothermia, or there is massive transfusion. And we can use the patient's IV cannula or catheter, which is free flowing. And but it is important to remember that we should not co-administer one blood component with other blood components. Like we should not co-administer PRBC and platelets simultaneously, or PRBC and plasma simultaneously in the same line. And we should not co-administer with other medications and the incompatible fluids. So which are the fluid for different blood components, a different blood transfusion set should be used. So which are the fluids which are compatible and incompatible? The only compatible fluid is a normal saline, which can be compatible with the blood. However, the other blood products like N/2 saline, or 5% dextrose, or 10% dextrose, so these are incompatible. The reason is that they are hyposmolar, and this may cause hemolysis. And the calcium containing blood products like RL are also incompatible, because the calcium will in this RL will cause precipitation of the clot factor of the anti-clotting agent, and therefore the clotting will be precipitated. So we should always try to transfuse PRBC in the cannula itself, without any other fluids or blood products. However, if you are not able to do, the only compatible fluid is normal saline. And what should be the duration for transfusion? For PRB, now whole blood is almost obsolete. The PRBC can be used for maximum of 4 hours, and after which it should be discarded. The RDP, single donor platelets, plasma, cryoprecipitate, they all should be used within half an hour. However, granulocyte transfusion can be given slowly up to a duration of 4 hours. So the document since the medical legal cases are increasing, so there has to be certain documentation during transfusion. So before transfusion, during and after transfusion, all these details like indications, the vitals, and any adverse events noted during the transfusion and timing of transfusions have to be noted properly. And briefly about transfusion reactions, which will be discussed in more detail. The transfusion reactions are classified as acute or delayed based on the onset. Typically, the acute transfusion reactions occur within 24 hours, whereas the reactions which occur more than 24 hours are typically called delayed. So the more important common acute events can be immune mediated or non-immune mediated. The common immune mediated acute transfusion reactions are acute hemolytic transfusion reactions, which occur due to RBC mismatch due to either wrong patient or there has been some error in the during the cross matching, or more commonly febrile non-hemolytic transfusion reaction. There can be other reactions like urticarial or anaphylactic reactions and Trelli. Some of the few non-immune mediated reactions include transfusion-associated sepsis if the blood bag has been contaminated, non-immune hemolysis, or transfusion-associated circulatory overload. And the symptoms this can be fever, there can be rash, dyspnea, respiratory distress, and hypotension. So all of this symptomatology can give us hint towards the type of the transfusion reaction. So what should be done in case of a reaction? In addition, first of all, we should stop the transfusion immediately if there is any transfusion reaction, and subsequently we should give the necessary medications which are given. In example, in case of hypersensitivity reaction, you can give antihistaminics, or anaphylactic reactions can adrenaline fluids if IV fluids if needed, and subsequently what should be done in case of reactions. So the sample do not discard the blood bag if there is any transfusion reaction. So we should take the blood bag and send it back to the blood bank for analysis and root cause analysis. And in addition to that, the sample should be sent for repeat blood grouping, DCT, and repeat CBC for all the cases where we are suspecting febrile reactions and infection because of contamination. Can send the blood culture from the blood bag and the patient. And hemolytic transfusion reaction, have to look for evidence of hemoglobin. So you can do plasma and urine hemoglobin, RFT, and LFTs. And if is evidence of respiratory distress, that can be because of Trally or circulatory overload. So investigate correspondingly like chest X-ray and pro-BNP. Thank you. Can take up questions at the now or at the end of ma'am's talk.
Yeah, probably we'll take up at the end of the month's talk.
Thank you.
Thank you, Devasis.
Okay, so Dr. Dharni. So should we start our next talk, and after that, after the end of the talk, then we can take up the questions?
Yes, ma'am. Yes, ma'am. We have only one question in the chat box so far, so we'll have all the questions at the end.
Okay.
I request all the other participants to post their queries in the chat box. So we'll take up all the questions at the end.
So allow me to share the screen.
Vinyan, can you make ma'am co-host? I think you're already co-host, ma'am. You should be able to share.
Is it visible?
Yes, ma'am. Yeah, we can see the slides.
Okay. So good afternoon all, and thank you Dharni for this opportunity, and I thank Dr. Devasis for delivering a nice talk, and he has already almost completely covered most of the topics. So I just want to give emphasis on a few of the points and summarize. So, as you know that this whole blood is collected and blood products are derived from it and utilized for different indications. So, below is the packed RBCs, above is the plasma, and in between there is a thin layer that is called buffy coat. Am I audible?
Yes, ma'am, you are.
So in between, there is a thin layer which is called buffy coat, which contains this leukocytes and platelets. So regarding the few practical points that how can we optimize pediatric blood utilization? We know that normally in pediatrics, we give 10 to 15 ml of packed RBCs. So when there is a whole blood unit that contains around 200 to 250 ml of packed RBC, and if we don't divide it, then there will be much wastage of the RBCs. That's why normally a unit, 1 unit of packed RBC is divided into 2 to 3 units, so that there will be utilization of the whole RBCs and without any wastage. Then there are few components we'll be discussing about. So component, we know that whole blood is collected normally in 450 ml bag. And after the collection of whole blood, there is soft skin is given and there will be separation of packed RBCs and platelet-rich plasma. Then when this platelet-rich plasma and again that hard skin is given, so platelet concentrate, which is normally 50 to 70 ml are collected, and then the rest are freeze frozen plasma. And then this freeze frozen plasma, again cryoprecipitate is derived from freeze frozen plasma, around 15 to 20 ml per unit, and the rest is called cryopoor plasma. So we utilize packed from whole blood, packed RBC, platelet-rich plasma, freeze frozen plasma, cryoprecipitate, all these things. So whenever we indent a bag of any blood product, we always have to check that what is the date of collection and expiry date. Normally, this whole blood or red blood cells can be stored up to 5 to 6 weeks at 1 to 6 degree of temperature. This is 4 degrees Celsius of temperature. Platelets are only stored for 5 days and with at 20 to 24 degrees Celsius with continuous gentle agitation. Freeze frozen plasma between minus 18 to minus 30 degrees Celsius for a year. But if we store it at minus 65 degrees Celsius, it can be stored up to 7 years. And after thawing of freeze frozen plasma, between at 4 degrees Celsius, it can be stored only up to 24 hours. But cryoprecipitate, similarly, it is stored as FFP. But cryo after thawing, it should be utilized within 4 to 6 hours. Otherwise, factor 8 in the coagulants, there will not be of much use. That's why it should be, after thawing, it should be utilized around 4 hours after thawing. Then regarding some transfusion transmitted infections, normally we know that whenever there is like blood donations, they screen for TTIs, hepatitis B, C, HIV, malaria, and this syphilis for VDRL test. And these viral infections are more important, and normally ELISA test is done to screen the TTIs. But now all the blood banks are adopting for this NAT testing, that is nucleic acid testing, which is a molecular technique. And why it is important, that it early detection of occurrence of infection, it is important, and it cut down the incidence of TTIs. So normally for this viral detection, ELISA test is utilized, which is very sensitive. But the only problem is that window period where this ELISA detects, there is much longer in this hepatitis B, C, and HIV. But when we use NAT testing, it can detect much earlier, all the infections much earlier. So though it is little bit expensive, but it should be utilized in all the blood banks, because if any patient suffers from TTI, hepatitis B, C, or HIV, then the drug therapy, the antiviral therapy, and the complications arising from this infections cost much than the NAT testing. But now most of the blood centers, blood banks are using the NAT testing. Then a few practical points like during administration of blood components, 22 gauge cannula is safe and for a constant flow, but normally in infants can't do that. So normally in infants 24 gauge can be utilized, but that's very small. 26 is not good. So in infants 24 gauge is also can be utilized. And there is no need for warming the blood before transfusion. So when we hang it, we can start in a slow rate, and after few minutes, the blood will come in for the come to the room temperature. Then IV tubing with a filter of 170 to 260 micron is utilized, and already Dr. Devasis has told that only normal saline is compatible with blood products, not any other solution. Then for cross-matching, we know that packed RBCs, this ABO and RH compatibility testing is mandatory. For platelets, it is preferred. And plasma, ABO compatibility matching is must. And in cryo, though ABO compatibility is important, but RH is not important for plasma and cryo. So regarding some fresh frozen plasma and indications, we know that fresh frozen plasma shelf life is 1 year, and it is before this clotting factors are available. This FFP was utilized for hemophilia A and B, and ideally it should be thawed in the blood bank. And ABO matching, we have already discussed that donor plasma contains A and B allo antibodies. So must be either ABO identical or ABO compatible with the recipient. And indications of FFP, that is hereditary clotting factor deficiencies like factor 8, 9, von Willebrand disease, and other cases like severe liver disease, disseminated intravascular coagulation, vitamin K deficiency. In these cases, it is utilized, and normally dose is 10 ml per kg. So thawing of FFP is important. Normally blood bank does thawing and give to the recipient. But if it is not available, the thawing bath, plasma thawing bath is available in the blood bank. But if it is not available, then some clean surface can be utilized. And if you're using water, ensure ports are above the water level. But blankets, armpits, heaters, these things should not be used. Then regarding cryo contains factor 8 and fibrinogen. So it can be utilized for von Willebrand disease. And because it is very concentrated, one packet is only hardly 15 to 20 ml. It also doesn't cause volume overload in cases of small children and infants. So indications are von Willebrand disease, hemophilia A, factor 13 deficiency, and 1 unit is utilized for 7 to 10 kg of body weight. Then the complications of blood transfusion, Dr. Devasis has covered most of the thing. So it can be immune-mediated, infectious, and non-immune mediated. Immune-mediated acute hemolytic transfusion reaction, febrile non-hemolytic transfusion reaction, anaphylactic reactions, allergic reactions, TRALI, transfusion-associated grass versus horse disease, post-transfusion purpura, alloimmunization. Infection, bacterial contamination, viral hepatitis B, C, HIV, parasite, malaria, and rabies. And non-immune mediated are transfusion-associated circulatory overload, non-febrile hemolysis, metabolic derangements, massive transfusion, and iron overload. So it's already discussed. To just summarize that this is acute hemolytic reaction. So it results from mistransfusion of ABO incompatibility red cells. So it is best prevented rather than treated. And transfusion reaction, febrile reaction, it is related to the presence of cytokines produced by the donor leukocytes. And this allergic reaction more common with plasma and platelet transfusions. And this allergic reaction is this paraproteins present in the plasma are responsible for the allergic reaction. That's why whenever normally the patients, the thalassemia patients where regular transfusion is given, so saline washed packed RBCs are given. So in saline washed packed RBCs, these paraproteins are removed and it causes less allergic reaction. So saline wash causes to decrease, saline wash is done to decrease allergic reactions, not for leukoreduction. So transfusion reactions like transfusion associated lung injury. And we know that when this anti-HLA or anti-granulocyte antibody in the donor plasma attaches to recipient WBC, then there causes activation of the complement, and there is pulmonary sequestration and activation of the neutrophils. There is cause cytokine release and endothelial damage, capillary leak in the lungs, and causes Raleigh. So normally the treatment is supportive. And some points regarding transfusion-associated graft versus host disease. We know that the pathophysiology is again the immunocompetent cells of the donor lymphocytes. So most of the time, these lymphocytes which are present in the whole blood, this causes most of this problem, starting from reactions to alloimmunization to infection. And alloimmunization, patients at a high risk of alloimmunization should receive leukodepleted or irradiated blood products. And as Dr. Devasis has discussed, in our setting, like most of the sickle cell patients and non-transfusion dependent thalassemia patients, we chances of alloimmunization is much more. And in those cases, leukoreduced packed RBCs are of much help. Then routine leukodepletion significantly reduces this risk in these patients, but routine leukodepletion is expensive. That's why most of the time for regular utilization, leukodepletion is normally not done. And avoidance of transfusion when not indicated is more important to avoid alloimmunization. So we are talking about this donor leukocyte. So this donor leukocyte is important for all these complications of transfusion, starting from febrile non-hemolytic transfusion reaction to transfusion-associated graft versus host disease to alloimmunization to infections. So that's why leukodepletion or leukoreduction is more important. And we know that fresh whole blood contains around 10 to the power 9 leukocytes. And when we do it leukoreduction, then the number of leukocytes gradually decrease. And with leukoreduction, one thing is that with some amount of around 2 to 3% of RBC and 10% of platelets are also lost. So there are two methods of leukoreduction, either pre-storage leukoreduction, which is done after the collection. Pre-storage leukoreduction is the best, but most of the time due to expense, as it is expensive and this technical issues, that's why pre-storage leukoreduction most of the time is not done. And post-storage leukoreduction is done at the time of issue blood bank and the time of transfusion. Most of the with using a leukocyte filter. So most of you must have seen this leukocyte filter, which is used on bedside. But it is pre-storage leukoreduction, which is most important and most effective. And now third generation leukocyte filters are used, which actually can reduce leukocytes up to more than 99%. And indications of leukoreduced packed RBCs, where actually patients are getting regular blood transfusions like thalassemia, and in sickle cell cases also aplastic anemia. In those cases, it is important, and those patients who are planned for bone marrow transplant, because these leukocytes, which are more important for all these complications of transfusion. Then regarding irradiation, there are some advantages and disadvantages associated with it. Advantage is that it decreases risk of alloimmunization and decreases the risk of CMV infection and prevents the transfusion-associated graft versus host disease. But the disadvantage is cost, and older RBCs may be light, so hemoglobin increase in hemoglobin may not be that effective. And the risk of hyperkalemia. That's why when one blood packed RBC is irradiated, it should be given most of the time within 4 to 6 hours. And because if you keep it and give it later, then chances of hyperkalemia is there. So what we use in our setting, that we try to give leukoreduced or irradiated blood products depending on the setting and what is the indication. and extended cross-matching whenever is there required that to alleviate alloimmunization, especially in sickle cell and non-transfusion dependent thalassemias, and a plan for SDP when feasible. Pooled platelets are also efficacious and effective. And we can consider decreasing platelet transfusion threshold to 10,000 in stable and afebrile patients, and minimize blood investigations and investigations-based transfusion support. So to summarize, anemia, bleeding, and coagulopathy are frequent in the critical care settings. Identification of cause is essential for optimal management. An imperative restrictive transfusion policy, like Dr. Debassis has already discussed. So restrictive transfusion policy is preferable for all blood products. Only use prophylactic platelet transfusion when total platelet count is less than 10,000. The use of plasma to correct coagulation abnormalities without clinical features is likely of limited benefit. And some take-home message is each transfusion is potentially harmful, so risk benefits should be evaluated in all the cases, and check for cross-match details, expiry date, bag number, patient details, screening results of TTI before charting blood component transfusion. Packed RBC transfusion should not exceed more than 4 hours, the transfusion duration, and in stable critically ill children, the transfusion threshold should be less than 7 gram percentage is safe, and plain transfusions based on targets and monitor should be monitored accordingly. And should consider using liquid-reduced blood products to prevent alloimmunization or transfusion reactions whenever there is necessity, and careful monitoring during blood product transfusion for complications. Thank you. So I think we have time. We can take few questions. Over to
Sure,
the
ma'am. Thank you, ma'am. Thank you so much for a comprehensive lecture. And thank you, ma'am, and Dr. Devashish, both of you. So we've covered all the points that need to be discussed. So we have 2 questions in the chat box. I'll read the first one. So I heard for the transfusion blood, using infusion pump is risky. It has a high chance of hemolysis. So there's a question is regarding using the infusion pump for giving the transfusion. Dr. Debashish, do you want to take it up?
Yeah. Okay. Like infusion pump is typically used in when the volume of blood to be transfused is less, and it has to be tightly regulated, like in very young infants and neonates only. So routinely, it is and these pumps are not used in older children. So, if the lumen of the if the lumen is very narrow, then yes, there will be an increased risk of there may be a risk of hemolysis, but if you at appropriate rates, the risk of hemolysis is lesser, and put in neonates and young infants, infusion pumps are more frequently used.
also infusion pumps doesn't contain filter.
Yes, so when you use infusion pumps, the recommendations are to use a filter in addition to the infusion pump.
Yeah.
Yes.
That's a very valid point. So the other question in the chat box is, how much volume of SDP can be transfused to a patient with 28 kg weight? I'm not sure, maybe.
So so based on the platelet count, we can transfuse STP. Typically STP will contain 250 to 300 ml of the product. So it will be around roughly around almost 10 ml per kg for this child of 28 kg. So the typical practice is to give like divide the STP into half, into two parts, and transfuse not at the same setting. However, having said that, if there is an indication that if you need to increase the platelets more rapidly, still you can up to 10 ml per kg in a single setting. The single setting can be used. For this child of almost 30 kg, and full STP can be used if the clinical condition requires it. The elevation in platelet count has to be more rapid. Then you can even transfuse the full STP.
Thank you, Dr. Devashish.
And the
So
expected
roughly for our teaching, we tell them less than 30 kg, I mean 27 to 30 kg, we give half unit. Anyone weighing more than 27, 28 kgs, we can give the full unit, like you said.
And another thing is that like SDP is getting the donor and the kit cost. So if the increase in platelet count is not that much is required for any surgery or something, then we can always divide it and utilize it over a period of 5 days so that we have time rather than increasing it, because the platelet half-life is very short. So that also depends upon for what you want to use SDP, for what condition. So if you want to increase the platelet count to very high level or to like maintain it over a period of time.
Agree, ma'am. So with that, I had a question which I have come across in some of the units. So the nursing staff sometimes are very particular that there should be a new cannula inserted for patients receiving transfusions, because most of our patients are already getting antibiotics and other medications. So is that something that you also follow in your unit? That a new IV line has to be placed for a blood transfusion?
No, routinely we don't for this for each transfusion we don't require a new IV line. The IV line should be patented, and that's it. If you need to coordinate means give some other drugs also simultaneously which can't wait during that time, then you can put another IV line. But for each transfusion we do not need a new IV line unless it is not working properly.
Okay, thank you. So I would like just to quickly summarize the most important thing, as we say, safe transfusion. Dr. Devashish had clearly highlighted that where the sample should be taken, how the forms should be filled, and how do we do the checking at the blood bank level, at the bedside level, before verifying and before connecting. This, though the process looks tedious, once we get to the practice, it is very easy and it is very safe. Once there is an error, we cannot compensate the complication for the complications. So it is always better to prevent the error and the complication rather than managing it later. So that is the most important take-home message from this class. And as Sonali ma'am also highlighted, the irradiation, leucofiltration, wherever it is indicated and necessary, we should be really following that. This is not only the responsibility of the nurses, but also the doctors who take care of it. And especially the point about transfusion in bone marrow transplant patient is, ma'am has really highlighted that it should be irradiated. And sometimes if there is incompatibility between the donor and patient, suppose donor is one blood group and recipient is another blood group, then there are specific criteria of which unit blood, I mean, packed cells to be given, which unit platelets to be given. That is also another point that we should keep in mind before we order the transfusion itself. So, and of course, the restrictive policy, like to avoid maximum transfusions as much as possible. And whenever it is needed, we take the utmost precautions to maintain the safety. So with this, if there are no questions or comments, we would close the session. Dr. Sonali ma'am or Devashish, do you want to add anything?
No, Dharni, you have very well summarized today's topic. So most of the time, like when transfusion should not be given whenever it is not absolutely necessary, because of all the complications associated with it. So whenever absolutely necessary, it should be transfused, and a restrictive policy should be followed regarding transfusion.
Agree, ma'am. Thank you so much. I request all the participants to fill the feedback form And I sincerely thank Sonali ma'am and Debashish for putting in their time and efforts for this class and teaching us so comprehensively. Thank you so much, ma'am and Debashish. With this, we close the session. I hand over to William, the eco person, to close the session. Thank you.
Thank you, Dharani.
Thank you.
Thank you, everyone.
Thank you.